So patients with cystic fibrosis have two ways that it shows up in their body. It's going to impact above the diaphragm in the lungs and below the diaphragm in the GI system. There's other effects throughout the rest of the body, but those are the most acute that they have to manage medically. So for the lungs, there's various drugs they can give to help with sort of lung chemistry and trying to help lungs clear better and increase and thin out the mucus in the lungs and prevent infection. In the GI system, the pancreatic ducts get physically blocked and scarred in utero. So as the infant's developing with cystic fibrosis, the mucus in its pancreas will start to physically block and scar the pancreatic ducts, which means that by the time the child is about 4 years of age, about 60 to 70% of CF patients need some sort of oral supplement to compensate for pancreatic function. And then as they get a little bit older, by the time they're sort of in their sort of age 6, 7, about 92% of patients need an oral therapy. They need this oral therapy because if they're missing the pancreatic enzymes, the biggest thing they're missing is a lipase. And the lipase helps break up fat so it can be absorbed and digested. And if you're missing that, then there's big problems with both calories and vitamins. So an adult friend of mine has CF. He swallows about 6,000 calories a day just to maintain his body weight. He swallows that because only about 2,000, 2,500 gets absorbed. He's on the highest possible dose in standard of care, but the problem is that he probably needs to go much higher. Going any higher on standard of care means you actually end up with something called fibrosis colonopathy. So the patient's colon will be attacked by the enzymes that they swallow if they have too much protease activity. And just to make it real, like for like, the average sort of pill burden for a patient on standard of care is about 40 capsules, and we think we can bring it down to 8 capsules. So a much smaller capsule and much smaller number of pills, which together we think will make a big difference for patient outcome. We also think we can titrate much higher. So one interesting thing with cystic fibrosis is that the best prognostic factor for lung health is body weight. So you need patients who, if their BMI is too low, then you see a direct drop off in lung function. But just as importantly, is patients that if they're at 85% or less of their target weight for their age, their mortality really increases. So patients who get healthier and heavier have better lung function, and patients who lose weight have more severe mortality. So it's not just a matter of how you're digesting your food and what does that mean. There's direct implications on lung health and life expectancy that come from adequate nutrition. The standard of care right now is porcine, is a porcine enzyme. It's a porcine-derived lipase. Back in the 1890s, the doctors figured out that you go the closest omnivore to a human. That's a pig. So if you take a pig's pancreas and try feeding it to a human, you get some residual activity. But the problem is that the pig enzyme is not acid stable, and our bodies and our guts are acidic. The pig gut is more basic than the human gut, and so the pig enzyme has evolved to work in a more basic environment. Humans being acidic, but CF being more acidic than non-CF humans, means that you actually have a much more acute need in a patient to actually be able to attack the fat with an acid-stable lipase.